I think post Francis, the challenges are not dissimilar to those that were there before Francis reported in February, but with an added element in that I think what he's reminding us of is that the quality of the services that we provide, particularly I think in our acute general services, is not good enough fundamentally, in that we need to look at raising those. So I think in the past acute hospitals have provided a broad range of services. They've allocated their resource in a certain way. We've made great strides in some areas like elective access, particularly healthcare acquired infections. But I think what we're now hearing is that they're almost a new set of priorities, and that the quality of the care as defined by the patient perspective and the outcomes, the clinical outcomes, is now, if you like, foremost in people's minds in a way that perhaps it wasn't when access was perceived as the key issue. And so we have to factor that in. So I think we were moving that way anyway. I think our key challenges were always around balancing finance, performance and quality. I think what Francis has done is reminded us very powerfully about the importance of the quality element. And so I think there are lots more in Francis about the way we operate, openness, more listening approach, etc., etc. But I think fundamentally it's about the quality of service. And for me, running 3 acute general hospitals, I think that links directly to our emergency care service. Actually, I think most of the issues that we heard about from mid-staffs probably relate to our acute general services rather than the planned services or the specialist ones. So for me, what I've taken away, the bottom line message for me from Francis is we need to make a step change in the way we deliver our emergency services so that they are running, if you like, calmer, more controlled, less prone to tipping into crisis, and in a way that allows us to take more cognizance of what you might call the patient experience aspects to them, like the level of privacy we afford people, the sort of dignity of the situation they find themselves, and so on and so forth. I think for me that's the bottom line from Francis. We've really got to factor that into our planning for emergency care going forward. I think the Chief Inspector of Hospitals is a really interesting development, and it's one that broadly I welcome, although we haven't seen the detail yet. So I think those of us in hospital sector are rather frustrated about the criteria for success, if I can call them that, by which we're judged. You know, of course we've got the targets and they measure aspects of our service, but I think we've always known that there's potentially a dissonance between our performance against a limited range of targets and what the local public are thinking. And so I think anything that brings about a more broader, a more insightful, in-depth look at the quality of what a hospital is providing is to be welcomed. And my understanding of the way the Chief Inspector role is going to work is it's almost something akin, coming closer to what we're already used to with peer review inspections for cancer, in that the inspectorate will be expert. They will have people who are running those services or who have run those services elsewhere. And so when they come in, they may look at specific services, but they will be looking at them with an expert eye. So yes, very much from the perspective of the patient, and that's right, but also with a greater degree of understanding of the services and the service provision than we've had before from visiting inspectors. So I'm expecting, depending on the level of scrutiny the hospital is under, and I think they've already said those with perceived problems will be visited more often. What I'm expecting is that the Chief Inspector's team will spend a little bit more time in the organisation and will know a bit more, have a bit more expertise in terms of what to look for. So I'm expecting it to be, in a sense, more rigorous in that they will undoubtedly have a perspective of this is a good service or it isn't, but it will be a view that's founded on a greater depth of information gathering, be it quantitative or qualitative. So I welcome it. I think the public has every right to have a sense of how their local hospitals or individual services are performing. And as a principle, that's absolutely right. What we would always say is we have to have a system that actually gives them that and that actually recognises the good and the bad and the indifferent and is able to reflect that. And from what I'm hearing about the Chief Inspector role, I think it's much more likely to be able to make that assessment than what we've had previously, so I welcome it. The financial challenge for 13-14 is in essence the same as it was for the previous year. So the baseline is 5%. We're fortunate not to have a historical legacy, so it's 5% for us. One would expect it to get more difficult each year. The easy wins have already been gained, so I think that's certainly true. My guess is that across the sector you'll find trusts will hit the real difficulty at different times. Mm-hmm. For us, we're relatively comfortable that we will manage 13-14. Our concern would be that there might be a step increase in difficulty after that. It's hanging there. Can I make next year's 5%? Yes. But how am I going to make the 5% the year after that and after that and after that? And I think that brings you into questions about transforming the model of service provision that we offer, and that's such a big issue that I think that's what would worry me. So I'm much more concerned about the future after next year than I am about next year. For next year, the job is to start getting those transformation programs into place, so that I can gain more assurance about subsequent years. So for me, and I may be in a relatively fortunate position, next year's 5% will be a challenge just like it was last year, but I think it's a manageable one. But as a chief executive, my concern is that I'm putting in place the foundations for the year after and the year after and the year after, when we're expecting the challenge to continue, and we won't be able to continue to do it by our, what you might call our traditional cost improvement methodology. So the way we need to transform our services, and again, I haven't got the complete answer for this, so I have no plan that I can show to anyone that shows how we will meet a 5% challenge per year for the next 4 or 5 years. I think we know the direction of travel, but I don't think we quite know what the end point will be. So I think there's no doubt that we need to start managing down acute activity. I don't think we'll see a big reduction. We might be able to hold it broadly where it is. I think given the demographic changes, that will be doing pretty well. I think what we do need to do differently is we need to work as a system. I think it would be very wrong to continue to focus on individual organisations in a number of things, but particularly the financial one. I think we need a system-wide approach, or a health economy-wide approach, to start working out how we're going to shift the model of care. And broadly, the transformation need is to move from an acute model of care to what you might call a long-term conditions model. Most people we admit acutely have got flare-ups of long-term conditions rather than new acute conditions. And we know from evidence elsewhere in the world that better proactive maintenance care could have prevented some of those admissions and improved health at the same time. So I think the challenge for us is to go around the services we offer, specialty by specialty, and start to say, how does your future role look different to your current role? And for many of our medical specialties, I think that's about providing year-round care for people with long-term conditions, including frailty, and of course the frail elderly particularly tend to have multiple long-term conditions. And I think when I talk about transformation, it's really about shifting from a rather reactive, treat the people who are acutely ill enough to come through our doors, to a system where we're starting to manage that disease load, that dependency load in the populations that we serve, not just on our own, but with community partners, primary care, social care, to try and reduce the, if you like, the need for highly costly, high acuity inpatient hospital care. That's broadly the challenge. It would play out differently in every specialty, but broadly we have to start moving towards a more preventative approach. And where I would disagree with some is that I think the acute hospital does have a role in that. I think we do have specialists and specialist teams who have that expertise, and we do it in small areas now. So the example I was giving, chest medicine, we do that for cystic fibrosis, but we don't do it for chronic bronchitis, which is far commoner. So I think I see local acute hospitals as evolving in that way. We're already providing post-discharge care in the home as an acute trust. We're already starting to work in what you might call front door demand management areas. And so I think we will grow our services in the kind of pre-admission and post-discharge phase of the patient journey. But we'll need to do that in conjunction with health economy, health and social care economy partners to try and bring down that, to try and manage the overall, if you like, disease load collectively more efficiently. So I think when I talk about transformation, it's a shift in the model of care, but it's also a shift in the way we operate. It has to be a more collaborative, partnering approach in the future. This business about sticking behind the walls of your own institution and each going for your own targets is not going to get us where we need to get to. Well, again, in terms of savings, yes, I think we as an organisation, as an acute organisation, will make the same level of savings next year. It's critical that we do. Once we start falling behind, then I think the finance will start to dominate, and we've already discussed the fact that we've got performance and quality challenges which are equal. So as a chief exec, I don't want to be talking about money all the time, but if I let the money get out of control, that is what I'll be talking about all the time. So we really need to keep on top of it. And as I say, our plans are pretty far advanced for next year, so I'm relatively comfortable. My nervousness would come from 14, 15 onwards, and that's primarily because as yet we haven't got anywhere near as far advanced plans as you would expect for a year's hence. So yeah, reasonable confidence levels for next year, but very conscious that we have to be actually planning hard for subsequent years, because all the advice we're getting is that the 5% challenge is essentially going to be with us for several years to come yet. The new commissioning environment is one that we're really pleased to see. So we're predominantly clinical commissioning group driven. About a sixth of our income comes from specialist commissioning. So most comes from the new CCGs. We've been working with them in shadow form for nearly a year now, meeting with them monthly. Relationships are very good. The conversation is definitely more patient, more clinically focused. Which we welcome. We've had better than ever dialogue between primary care and secondary care doctors, which I think is to be welcomed. So my sense of the new system is it's positive. They seem to want to work with us in a collaborative way. Their challenges are the same as our challenges, but I think they're coming in at a very difficult time. They probably couldn't choose a more difficult time to come in, and they're new to what is a very big job and a very complex job. So partly I think we're keen as an acute trust to support them, because I think it's in all of our interests that they get up to speed and take control of the system as soon as they can, and that's what we're trying to do. But broadly speaking, their priorities are things like emergency care is probably the number one for all of us at the moment. They're very keen to work together with us on that. and we welcome that. We are starting to get a better understanding between general practitioners and hospital consultants, something that I think's drifted in the last 5 or 10 years. So I wish them well. We are actively supporting them. I think there are a few anomalies in the structure of the new system that leave us uncertain. The tendering rules, for instance, it's a complex debate. I don't really know where that's going to land, if I'm honest. What I do know is that the people on the ground all share the same priorities in terms of service improvement, and we've started well in the sense of having strong and constructive relationships. Well, it's April 13. We've had an enormously long build-up to this new structure. We seem to have been debating it forever. And my sense as a CEO is that there's more unsettlement, more uncertainty in the health service now than I can remember, both about the future, but also about the way we're going to operate. Francis talked a lot about the need for a new culture. What's that going to look like? When are we going to see and feel it? Is it going to come at all? So I think there's a sense about the way we operate being. We all think it's going to change, and I think most of us feel he's right, it needs to change, but we haven't seen it yet. So is that, what impact's that going to have? And then you come back to the fundamental challenges around finance, quality and performance, and none of us can, as I said earlier, can articulate the end point. So someone described it to me the other day like walking forward in the fog with a torch. We can see a certain distance, and we hope we're walking in the right direction, and each time we take a step forward we can see another step forward, but it's quite difficult to articulate to an organisation. For instance, I've got 11,000 staff. Actually, this is where we've got to get to, and this is how we're going to get there. It's incremental, but there are some fundamental underlying questions that are very hard to answer. So if someone says to me, well, is Heart of England really going to be 25% smaller in 5 years' time? Actually, I don't think that can happen. So, but that's officially what we're working towards. So I suspect what we'll be doing is considerably more activity for the same financial envelope. But I suppose the point I'm making is it feels uncertain. I think we all broadly agree on the direction of travel, but I'm not sure that we can say to ourselves, if we do these 10 things, we'll be fine in 5 years' time. I think 5 years' time still feels very uncertain. And so I think what we have to do is to do what we know is right and just move forward. But I'm sensing a lot of uncertainty generally, a lot of will too, a lot of goodwill still to do the right things, but uncertainty about where it's going to lead us and how soon we're going to feel that we've kind of cracked the problem, if I can put it that way.